Convention Center, and we have a very interesting course here. There are some very senior persons who are widely experienced in a small incision cataract surgery, and there are some youngsters. So we would be just talking a little bit about SICS in difficult situations and how to manage them and how to improve your results. So we don't find many audience here in this early morning on the last day of this beautiful Asia Pacific American this meeting, and we hope this course will continue. Timing थोड़ी सी अगर दिन में हो जाए. So since Dr. KPS Malik and other speakers are awaited, I'll request Dr. Pranav Saluja to give his talk. Dr. Pranav Saluja is from Prayagraj. He is working in Center for Sight. He was previously in Regional Institute of Ophthalmology, MLN Medical College, Allahabad. So, Dr. Pranav, please.
Thank you, sir. At the outset, I would like to thank Professor Kamaljeet, sir, and respected seniors for giving me this opportunity. So, I'll be talking about SICS on astigmatism. So as we all know that there has been technological advances in ophthalmology, and it has grown by leaps and bounds. And it is not only our job to improve the patient's vision, but also to refine it. And proper management of astigmatism can lead to excellent visual outcomes. So to achieve emetropia is the target nowadays, and the goals are mainly painless visual recovery, spectacle independence, correction of pre-existing astigmatism, and repeatability of the surgical result with a sustained quality of vision. So just going on to the basics, the types of astigmatism, as we all know, is with the rule and against the rule. And against the rule is the one which is more common in the older patients, which is the cataract patients. And so it is better to make the incision towards the temporal so that the astigmatism is controlled. So the factors affecting astigmatism is mainly incision characteristics, the use of cautery, and the use and non-use of sutures. There are other multiple factors which we'll see later on. So how do we measure this astigmatism? It is mainly with the help of retinoscopy, keratometry, and corneal topography. And we can use a manual keratometer, which is preferred in patients with poor fixation or if there is corneal abnormalities, distorted Meyers, and a highly toric cornea or a dry cornea. In rest of the cases, we usually do a topography. So how do we correct this astigmatism with SICS, which is the topic for today? So the main thing is the incision characteristics. So as we all know, if the size is larger, there is greater flattening, and if the size is smaller, then there is lesser flattening. The distance from the cornea is also important. The farther the incision from the cornea, the lesser the astigmatism, and vice versa. And the configuration is another thing which is important. It is always good to target and hit the astigmatically neutral zone. So what is the astigmatically neutral zone? This was described by Koch, and he described that surgically induced astigmatism was inversely related to the distance of the incision from the corneal center. And the funnel's base is at the limbus, which is here, and it moves away as it widens. The incision which is made within the funnel is usually astigmatically neutral. So if we make it the incision here near the limbus and it is in this zone, then the astigmatism will be almost zero. And if we make it farther from the cornea, then we can also make a larger incision and then also have a astigmatically neutral zone. So this induces almost 0.25 to 0.5 diopter of astigmatism only. So the other thing is incision type. Superior incision has been found to have more chances of astigmatism, and although it is easy to learn and we usually learn during our residency, but temporal incision is the one which is better for treating the astigmatism. And also in cases where there is deeper sockets, smaller eyes, or future trabeculectomy is considered. So this is the concept of coupling, which suggests that the flattening effect is achieved at the tissue and the steepening is produced 90 degrees away. And surgically induced astigmatism is almost -1 to -1.5 diopter at 90 degree if a 6.5 millimeter incision is placed. So again, when we flatten one meridian of the cornea, we steepen the other meridian. So it has been studied in various studies, and it has been found that superior-temporal or temporal incision is the one which should be considered if we want to correct the astigmatism. And the incision length, as we talked about, the larger the incision, the more the chances of astigmatism. So excessive cautery also increases in astigmatism, although me as per do not use cautery during SICS. But in cases where we use cautery, there can be scleral shrinkage and scleral necrosis and lead to astigmatism. So how do we correct this astigmatism? Mainly in mild astigmatism, it is just neutralized by changing the site of the incision. So if we operate on the steeper axis, then mostly the astigmatism is controlled, and we can vary the construction according to the astigmatism that we see on the topography. So limbal relaxing incision, this is another thing. With a 90% depth and a steeper meridian in front of the limbus, we make the incision just in front of the limbus and at a 90% depth to correct the astigmatism. There are pre-existing guard blades which are present. This is a video showing astigmatism. We make a incision and then make a tunnel, but we do not enter the anterior chamber. After this, we mark it according to the amount of astigmatism that we want to correct. Usually a 30-degree or a 60-degree incision has to be made and just made in front of the limbus at a 90% depth. So this is a guarded blade which can be bought from anywhere, and this corrects the amount of astigmatism whichever according to the calculator we have calculated. So it is imperative to check the calculation to prevent any mishap, and a 90-degree off is the most common error. And again, operating on the steeper axis is what we have to do. So there are various normograms which are given. There is Miller, Gill, and Nickerman, which can be helpful. And there is also an online calculator, which is lricalculator.com, with the help of which we can correct the amount of astigmatism that we want to correct. So again, these are the details and multiple of normograms which have been given by Gill, and the amount of astigmatism that can be corrected. So the advantages in this is there is less tendency of shift to the resultant cylindrical axis. There is less chances of irregular corneal flattening and irregular astigmatism, which is in case of an arcuate incisions. And it is easier to perform than a shorter and centrally placed corneal relaxing incision. And also, as we've already talked about the coupling, it gives a 1:1 coupling ratio. So there is less amount of chances that the astigmatism won't be corrected. Then this is another thing, if we want to correct a higher amount of astigmatism, usually a opposite clear corneal incision is given. This was described by Lever and Dahan, and the mean astigmatism correction achieved with this technique was around 1.66 plus minus 0.5. So this technique involves creating two biplanar incision, which is 3.2 millimeter on the steeper axis again. And although there is lack of predictability and absence of nomogram, but this also corrects around 1.5 diopter of astigmatism. So this is a flowchart depicting what we've already talked about. If there is a lower amount of astigmatism, 1 diopter, we can just put the incision on the astigmatically neutral zone so that the astigmatism is very minimal. And moderate, in cases of moderate, we can put a small incision, make a straighter incision so that the astigmatism is corrected more. And if we want to correct a higher grade of astigmatism, then usually a combination of the limbal relaxing incision and the incision profile is needed. If it is post-operative, then astigmatic keratotomy can be done, a wound revision can be done, and even a laser can be done in these cases. So take home is that first of all, a pre-op and intra-op identification of the astigmatism should be done. And as we've already talked about, a step ladder approach should be done according to the amount of astigmatism that is present. And technique can be effectively combined for higher levels of astigmatism. And again, always apply the incision on the steeper axis. Thank you.
Thank you, Dr. Pranav, such an excellent presentation.
Thank you, sir. Thank you.
Any query?
Now, may I request Dr. Sharma to please. Dr. Sharma is professor at the Regional Institute of Ophthalmology, Allahabad. And she's an excellent SICS surgeon. She can do wonderful keratoplasties and also phacoemulsification. And apart from that, she has interest in so much of ocular disorders, surface disorders. So may I request Dr. Shama to please give her talk. पास करना पड़ेगा.
Good morning, everyone. First of all, I would like to thank APAO and AIOS for giving me this opportunity, as well as I'm very thankful to Professor Kamaljit Singh sir to make me a part of this useful instruction course. I would be giving my talk on SICS with pterygium.
Hello.
According to a recent study in South India, at least 1/10 of OPD patients have pterygium in at least one eye, and nearly half of them have coexistent cataract. UV radiation is an important predisposing factor for both these conditions, so should we deal with them simultaneously? The magnitude of problem increases as we move towards south. It is more towards the equatorial regions. The concern with pterygium is mainly about the pterygium-induced astigmatism, which affects IOL power apart from cosmesis. Studies have demonstrated that even a grade 2 pterygium may induce about 3 diopter of with the rule astigmatism. Excision of pterygium, it induces changes in both the meridia and both the corneal surfaces. The persons who are predisposed to these coexisting conditions, they are mainly from the lower socioeconomic strata who choose to avoid spectacles for various reasons, and unattended pterygium during cataract surgery increases the postoperative refractive errors, rendering the patient optically blind. So this pterygium associated astigmatism is sum of pre-existing astigmatism as well as pterygium induced astigmatism, and both of them are independent variates. Patients of more than 50 years usually have against the rule astigmatism, as pterygium induces with the rule astigmatism. The pterygium induced astigmatism will depend upon grading, and the grading of pterygium has been variably described. One given by tan depends upon horizontal length. The pterygium surface area also decides the amount of astigmatism, and its vascularity was taken into consideration by Sang's classification. Refraction is very difficult in these cases when they are coexistence, and in addition, pterygium induces hemiastigmatism, making the calculation as well as the acceptance of cylinder poor in these patients. Keratometry detects astigmatism only in central 3 mm of cornea. Topography is the best tool for this purpose because it gives central as well as peripheral astigmatism, but in large pterygium it is neither feasible nor required. Pterygium-induced astigmatism is reversible for the most of part. Repeat keratometry after 4 and 6 weeks is done to look for stability of the cornea. Period required for stabilization may vary in different patients and in different grades of pterygium. Change in corneal astigmatism is positively correlated with preoperative grade of pterygium as well as the preoperative astigmatic value. More steepening is detected when bare sclera is performed, whereas mode of graft fixation has no correlation in change. Sequential surgeries have proven with time to provide better outcomes than simultaneous surgeries, and same is true for cataract and pterygium. But there are some patients who should be taken for simultaneous surgeries. There is no need to go for sequential. Like if you have a very small pterygium or low or absent astigmatism, the keratometry shows regular Myers and regular central corneal curvature on topography. Now this is a small video showing simultaneous surgery. In this we first remove the pterygium. We make an incision, make the subconjunctival dissection, and hold this pterygium tissue and excise it as medially as we can so as to remove all this growth which is underneath the conjunctiva, because this is responsible for most of the poor cosmesis, regrowth and everything. Then we avulge the pterygium, make the sclera bare at that side. After harvesting the graft, we can keep it in bowl and proceed with the SICS surgery in a routine way. Once we complete with the SICS surgery, then we take the graft and fix it either with glue, suture, electrocoaptation, whatever is your preferred mode, and close the case. The graft harvesting, some people have suggested it from the pterygium tissue itself, but somehow cosmetically it is unacceptable. So if you have any issues with harvesting the graft, amniotic membrane is a good option. Regarding the position of tunnel, the superior tunnel negates visceral astigmatism to some extent. For double-headed pterygium, you don't have an option, you have to go superiorly. In superior conjunctival scarring, as well as in less than 1 diopter of visceral astigmatism, temporal incision has to be performed, and you have to look for scleral thinning due to previous surgeries. The incision should be watertight, and you should have low threshold for suturing, and antimetabolites have to be avoided. Regarding the IOL power calculation, we reduce the IOL power by 0.5 diopter in grade 2 and by 1 diopter in grade 3 pterygium. There are certain regression formulas which are available, but it depends upon data from other eyes, so I consider them less reliable. Astigmatism management, if you are doing a simultaneous surgery, then we only plan for incision on the steep axis. Any other things are avoided. And in sequential surgery, the management of astigmatism is just as previously described by Dr. Pranav. Now, this is one of the cases. It was TANS grade 3 and SANS grade 2. Prior to pterygium surgery, the vertical astigmatism was 43.75 and the horizontal was 40.25. So we went ahead, did a conjunctival autograft with electrocoaptation. Corneal topography prior to cataract surgery revealed that the astigmatism, the vertical keratometry became flatter by 0.75 diopter, whereas horizontal one steepened by 4.25 diopter. So there are change in both the meridians. We went ahead and did this is the topography after cataract surgery, which was performed with the incision on the steep axis, and you can see how regular the cornea has become. The vertical astigmatism is now 43.5 and the horizontal is 44. So in conclusion, I would like to say that the sequential surgery is better than simultaneous surgery as it prevents postoperative surprises. If simultaneous surgery is to be done in candidates not fit in the criteria, then please reduce the IL power. If it is grade 2, then 0.5. If it is grade 3, then 1 diopter has to be reduced. And please do not attempt for astigmatism management in simultaneous surgery. Thank you.
Thank you, Dr. Sharma. It's a wonderful lecture. And in pterygium, we all know that if you do simultaneous surgery, at times it becomes difficult to get the exact IOL power calculation. So when the cataract and pterygium both coexist together, usually the best option would be to first do pterygium and wait for 6 months and then do the surgery. In smaller pterygiums, you can do simultaneous surgery. Although in Indian subjects, it's very difficult to explain to them that you come after 6 months and then we will do cataract surgery.
I think, so, I'm sorry,
Yes.
6 weeks should suffice.
Some say 6 weeks, but
6.
the 6 months is the ideal time
Okay,
for
sir.
getting the. Actually, I also presented this.
Okay, sir.
2 दिन पहले ही तो थोड़ा knowledge हमारा.
Okay, sir.
तो 6 weeks हम भी
Yes.
नहीं बढ़ाया था.
Yes, sir, yes.
So 6 weeks and what I say is that it's 6 months only. हर चीज़ में हमारे यहाँ पैरालिटिक स्क्विंट हो जाए तो 6 महीना, सप्ली लग जाए तो 6 महीना. So everything 6 months. So this way you can remember. Thank you so much, Dr.
Thank you, sir.
May I request now Professor S.P. Singh, ex-director and principal of MLN Medical College. He has a wide experience on SICS, phacoemulsification, highest number of cases, and all the records that you hold in cataract, he has broken all the records and does wonderful surgery. So you listen to this talk. He has lots of video cassettes on his small people. Thank you. Dr. S.P. Singh, sir.
Thank you, Mr. Dr. Kamalji, for such an excellent words to me and encouraging to me also. Thank you so much. Yes, this is not. ये नहीं है. Good morning to you, one of you. Yes. Yes. Okay. Thank you so much. So I am going to present the SICS small people. As you know, good metastasis is one of the very important part of the successful cataract surgery. But you know, certain situations, certain cases when the people is atonic or in post-diabetic cataract, there's a lot of sanikia and some other conditions like isolation syndrome and some scenario-rigid people, other are when this use of the anti-glaucoma for a long time, the people is not responding to the pharmacological agents. So in that situation, you have to adopt certain other devices, other techniques as well. So I would like to directly coming to the video for different cases and different techniques. So you know, this is a case of the post-diabetic, lot of sanikia along with the cataract. So first you have to inject the viscoelastic substance and break the sanikia. But still, in some of the people, membrane is in the this marginal is there. So now you can do this is my innovative technique in which even such a small people how you can make the larger rexis by pull and push method with the help of Y-shape, Sinskey hook and the curve Sinskey hook. You can do the rexis with such a small people. Otherwise, in such a small people, if you use any devices, expanding devices, what happens is damage the inspectors and the post-operative permanent dilation exits. So you can see how with such a small people how you have made the larger, and then with bimanual technique, press the nucleus at one end and then lift it. It will definitely pop out from the other end, and then bimanual technique remove it. Very easily you can remove with such a small the people, and then the card can be washed by stripping. First you have pull in the center, and then you can go for implant the IOL. Such a small people how you can implant. Then another case you can see how it is again. The small people not respond to any pharmacological agents. So again, how you can approach it, you can see this make a side port, and then after viscoelastic substrate, just do the membranectomy. The along the margin all around there lot of sanikia and margin atrophied. So first you have to remove all around the pupil with the help of micro scissors from different ports. You can go and then all around this do the membranectomy along with this perifibrous membrane that is known as pupillary edge resection, because you have to atrophied area have to remove. Still people not dilate. I am doing this stage pupilloplasty with the help of two Sinskey hook. And still people not dilate. So again, this is my another innovative technique, the pull and push method that had been published in the year 2017 in the International Journal. And then you can pull it with a Y-shape Sinskey hook, and then gradually you can enlarge all around. You can see the pupil is small, but you can see how large rexis can be made in small pupil. So again, this small hydrodexis, and with the help of double press it at one side, then another end will pop out from this comes, and then with the rotational technique, here you have to lift and with the help of Sinskey hook, lift it, rotate it, slightly lift, and some anterior movement, and then even in such the email post-operative people can be maintained very well if you adopt the combination of different techniques. And then you can see how in such a small people you can implant then you know this is an rigid people which is not responding to the any mediatic deck. So in this case I'm just decided to use some of this people expanded devices. The most commonly available is the iris, the iris hooks. So by this paracentis equally evenly placed, then This is very easy. This insertion of the rexis is very easy, and one has advantage over the other. That with the help of, say, you can adjust how much you want to dilate the pupil. Otherwise, in other expanding devices, they are fixed. You can't adjust the stretching of the iris. So, with the help of very easily, you can remove it with the phacopressure, and then it is nothing going to damage anything. So this is a very important device in such a situation. But only it has a drawback that if it stitch more, what will happen is it damage the inspector and the pupil become very irregular. So if you have to adjust the stretching, how much you want to stretch to dilate it. So this is the SurgerySICS syndrome, case of SurgerySICS syndrome. Again it's not responding. So there is another devices in this case. This is, Gupta ring. This is very simple, very economical as well. So it can be inserted with the help of simple IOL injector also. This having you can see how easily you can load in this very simple. There's a Gupta ring, alternative to the Mulligan ring. So you can see how to engage it very easily. It will less time to engage. It had the advantage that it did not need to any further entry or paracentesis. You can see how easily you can engage. First, during injection, you can engage at 3 points, and then lastly from the superly. And then you can see also, even though it is popular in the phaco situation, but in SICS also it can be used. And in throughout the procedure, this is not going to disenclavate. Disengagement of this Gupta rings, you can see how much large nucleus you can remove very easily, and you can see the circular rexis, and all the procedure. This is nothing. The Gupta is nothing going to disturb anywhere. No, and you can see very easily this removal of the ring. Just with the help of Sinsky hood, just disengage it and catch hold of one point, and you remove it very easily. So again, this is a very good device in such a situation, small people. But even in that case, there is some inspector damage. So how to avoid this? My another innovative technique, without using any dilating devices, either expanding devices or cutting all around. How you can do this successful surgery in such a by my innovative technique without damaging much. And even this situation very difficult to, in this size of people, is very difficult to do the phaco, but SICS can be performed with by this with STNB type and blue. With such is the then all the time you can expose the whatever area with the help of this Y-shaped hook. This press it one end and then pull with the help of curve, and then by direct observation, you can make larger rexis in such a small pupil, but you have to be very careful. Otherwise, chances of there's one drawback. You can see how much large area, large rexis has been made. This how you can this prolapse the nucleus, very important part. Small. First, we have to press it to one end, and then you can see by rotation and lifting. With the another left side slightly, lift it anteriorly, and how you can be such all around you can see the pupil, how this pupil, there is no damage to inspector anywhere, and this pupil, post-operative pupil is maintained very well. So this is again very good, but it requires a lot of experience. In initial cases, you can do similarly another case just to show that innovative technique to maintain such a small pupil, how you can remove the nucleus. Once you progress, then only two parts is difficult, rexis and the progress of the nucleus. So you can see this with two instruments, simple instrument, Y-shaped. They press it one corner and do the all around the rexis, and then use at this point of junction. You can use this curved curved hook, and then again from another port, just press another the iris, and this you can see, and then under direct observation with the help of this utrata forceps you can do. But then you can see how these small people. So first you have to press here. Then with the help of Y-shaped hook, catch both the iris as well as rexis, and then polarise the nucleus very well by rotational movement and slightly having this lifting movement. And then cortex, you can sometimes you can use the, you can see whatsoever the cortex is present. So all the time you can see how the pupil is maintained. This is the last case. Again, this is difficult. You need some of the combination. You can see how it is difficult cases all around the pupil. The pupillary membrane is there, synechiae is there. So first you have to do the membranectomy with the help of micro scissors from different pericenter. You can see all around. You can see remove the this peripupillary membrane, and along with the this as resection. You can see this how this is very important step. And then again you can see the rest is very easy. Again, in this much sufficient, you can add the other device, that is pull and push method, and then you can just pull it and then gradually make this rhexis. This is the important step. The rest is very easy. The nucleus, the pupil is stretchable. It can be removed very easily. You can see it prolapse nucleus in the anterior chamber. Rest is so this is the aim of the in such cases you have to maintain the post-operative size of the pupil very much to prevent any kind of glare, any other photophobia, etc. Thank you very much from Holy Kum City, Prayagraj.
Thank you, Professor S.P. Singh. It's a wonderful talk. I always admire you for this. And these are not just few videos that you can see in this. He has lots and lots of connection, keeps on changing. I don't know, how do you have this museum of this? So many small incisions, you must not have seen anywhere. So two things are very important, as sir has pointed out. One is that you make a good capsular access with the pushing of the iris, push and pull method, which works everywhere. Push and pull works everywhere. So this is wonderful technique wherein you can do a capsular access. And secondly, in all complicated cataracts, because of uveitis, we find that the cataract is usually soft. You don't get hard cataracts. So it's easy to take out the nucleus out of the bag and then take out from the incision site. So that is a very good thing that Professor S.P. Singh has shown. And you have to come to Allahabad to see his wonderful surgeries being performed there. Thank you so much. Now may I request Professor Ruchi Goyal. She is from Delhi and professor at Maulana Azad. She has left now and into private practice. Everybody is coming to private practice these days. Shama, yours is the next number.
No. I'm working somewhere. So good morning, everyone, and a nice Sunday morning to all. So I'll just, Dr. Kamaljeet has very kindly invited me to this talk, and I'll just go about how, when you get a case of glaucoma with cataract, which I think we keep getting day in and day out, what are the different approaches that need to be done? I'll touch upon the management in the sense the planning part and the surgical part. So whenever a patient is coming to you, one thing is you need to see how well the glaucoma is controlled. So, okay, now I think people can see me well. So, how well the glaucoma is controlled. So, preoperatively must have a very good evaluation of the optic disc, the intraocular pressures, and if you feel that there is some kind of cupping and you feel that it is a suspect, please do your pre-op investigations prior to cataract surgery, because you may end up giving poor results and the patient will be after your life, after the surgery, that why have I not regained vision. So document. An OCT RNFL is a very simple, test which can just document that yes, there is some kind of nerve fiber loss. Of course, there would be cases where with advanced glaucoma where you cannot get a OCT RNFL also. Then the other thing is you have to decide whether the patient is going to be controlled just by my cataract surgery, because we all know that angle closure glaucoma, now the standard treatment, in fact, what is happening is if the patient is predisposed to an angle closure and you do remove the cataract, many times these patients would, will reach the target pressure. So again, you need to decide whether you do a cataract surgery alone or you combine it with a combined surgery. Now the next question is whether you are going to do an MIGS, minimally invasive cataract glaucoma surgeries, or you want to go for traditional trabeculectomies, or sometimes you maybe even need to do valves. Now I'll just push out the valves out of the system, because here we are all supposed to be dealing with day-to-day cases. So let's say MIGS. MIGS, yes, it can be done. Before you go in and construct your tunnel, you finished your minimally invasive glaucoma surgeries. It's a very easy procedure, but remember, many of these patients, after doing a minimally invasive glaucoma surgery, they may have a little bit of post-op hyphema. Now, cataract patients, they are so tuned that they come and say, ki, agle din, why are we not 6/6 or 6/9? So, those kind of things you have to, discuss and plan before you go in for these kind of surgeries. Now, whether to do trab or not. So, if you think that your target pressure cannot be achieved, let's say, when I mean target pressure, let's say if it is about 0.7, 0.8 cupping, and you're doing just a cataract surgery, you know that your target pressure is not going to be achieved just simply by doing a cataract surgery. So, there you can, if the patient is going to be a compliant patient and you think he will, take the post-operative anti-glaucoma drugs, you can simply add anti-glaucoma drugs. If not, then especially rural areas, the patient just don't put any drops. So there it is better to do a combined surgery. Now these patients, the problems that can be, again, you have to divide whether it's again primary or a secondary angle closure, or a primary open or secondary open. It's a very vast range of classifications, but as it is, these patients may have, as I said, there could be small pupils, previous attacks of glaucoma may have occurred. The patients may have floppy iris, they may have a shallow AC, there may be a presence of pre-existing synechiae, there may be presence of pre-existing trab. So most of us like to do a superior SICS, and there you need to shift your site to temporal SICS. Also remember that whenever you're doing a trabeculectomy combined with it, you don't want to injure the conjunctiva. So what you need to do is do minimal dissection of the conjunctiva, leave the conjunctiva as virgin as possible so that you don't have a post-operative fibrosis, because that may lead to failure of your trabeculectomy. So let us see, this is one of the, a very good investigative tool which has come into the system now. I'm not saying that you have to do an anterior segment OCT in all patients, but if you have this, you can always document and make the patient understand. Just look at this. It gives a very clear picture that this patient, you can see there is the lens thickness increase, and the lens is actually pushing the iris and decreasing the opening of this angle. So you can simply explain to the patient that maybe just taking out this cataract, you will be all right after the, the pressures are going to be controlled. Now, so I've already told you, and of course lens-induced glaucomas where you need to go in for these surgeries. When I say lens-induced glaucomas, maybe let's say about 2 weeks the patient has already been into attack and has already developed synechiae. There you need to do a combined surgery. So let's have a look at the videos now. So this is how I do a SICS. So this is a frown incision, and you can see I am creating a small block here. So this is a square which is created right in the center. And remember, my incision, the external incision is about 1.5 to 2 millimeter from the limbus. My internal dissection would be again 2 millimeter into the limbus. This is the side pocket dissection, which is extremely important. And this is the Blumenthal technique which is being demonstrated. You can use any technique of SSCS, doesn't matter really. A rhexis, of course, has to be perfect, because remember, whenever you're doing a combined surgery, your IOL has to be in the bag. If it is not in the bag, you will have problems. So always IOL into the bag. This is hydrodissection. The nucleus is prolapsed into the bag. Again, there would be patients with very shallow ACs where you need to inject lot of viscoelastic, because otherwise you may end up injuring the endothelium. So this is the, now remember, now you have to do a very good wash. And what I do is that, suppose you are not able to, you have a very floppy iris. Many of these patients are going to have a floppy iris. So what I do is simply put a suture for a while, let the chamber become stable. I use my band, you can use your Simcoe, but you can, bimanual is a very good technique to give a good cortical aspiration. Put in the IOL in the back. Now this is how you, create a sclerostomy. And this is the sclerostomy being created. being created, and I use a MVR blade, and then I cut a block, and the interior part I just leave intact, because that will help in preventing the collapse of the chamber, and also it will help in preventing the against the wound drift. And after that I simply close the conjunctiva with the sutures. So this is a pre-existing trabeculectomy bleb, and here instead of you see the bleb is located superiorly, so I have made a temporal incision now. So this is a temporal incision, and here you can see minimally dissecting the conjunctiva so that you do not injure the bleb present in the superior location. So once you enter, now remember this is a already pre-existing bleb. So what is going to happen is that there will be a lot of hypotony, and there would be presence of some synechia because of this bleb. So here maybe the anterior chamber maintainer, the pressure created by it may not be enough to push the nucleus out. So again, the chamber is shallow, so a lot of viscoelastic, and now I've used two techniques. You see I've used a microvectors to pull this nucleus out. I've used the anterior chamber maintainer to keep my chamber deep all through, and I've also used put a suture at the end so that I don't have a leaky bleb. Now I think, sir, I can stop here. No problem. So the take-home message is that these patients need to be, before you start your surgery, ensure you don't drive very high pressures when you just start your case. So if the pressures are high, you can give a Manadol, give a massage. No topical surgeries, no combined surgeries are not topical surgeries. They have to be under a block. And suppose the patient has a cupping of 0.9, advanced cuppings. Do not suddenly decompress, because that can cause wipeout. So slow decompression, put your MVR, slowly release vacuous, do a slow decompression. If your chambers are shallow, use high molecular weight viscoelastics so that you are able to protect the endothelium. Always put the IOL in the back. That's of paramount importance when you're doing a combined surgery. Do a good tight conjunctival closure so that you have a good bleb. You can use MMC simultaneously. MMC, I like to use this. I like to use it for 3 minutes, the 4% one. And post-operatively, now there is a fashion of not giving any cycloplegics, but any traps, please ensure that you have your pupil dilated and you have cycloplegia. That's extremely important for a good functioning bleb post-operatively. Thank you so much.
Such an excellent talk. Now I would like to request Dr. Kamaljeet Singh to present his talk. As you know, he is a chief instructor of this particular course, and has a lot of experience in doing SICS in most of the difficult, I can say, all kind of cases, and simplified. He has simplified the technique as well. As you know, along with we are sitting with Dr. T.P. Lahane. He has performed highest surgery till date. Is doing the SICS and doing so many camps, organizing rural area, urban area, suburban area. So, and Dr. Kamal is also this particular technique that SICS is still. Yes, Kamal.
Thank you, Professor. So we first of all welcome Professor Lahane and Dr. Professor Ragni Parekh in this important session. And SICS, as you all know, is a faster surgery. It's very cheap. And last time in Kumbh Mela, we had this kind of picture. And these are the kind of patients who come to our hospital for SICS or maybe cataract surgery. They don't know which surgery we would be doing. And they are ever thankful. Whatever you do, whether you do SICS, whether you do phacoemulsification or conventional ECG, IOL, they are immensely thankful. So we still do almost 80% cases in Allahabad and do SICS. So it's always said that if you serve the poor, you will be remembered forever. And sometimes we do SICS and can be done through very small incision. I'm just touching a little bit about the modification that we do in SICS. So this is a hypermature cataract, you can see. And in this, doing capsular access is difficult. I usually use a forceps to do capsular access, and a large capsular access is usually required in SICS, whereas in phacoemulsification you just do 5.25, 5.5 millimeter. Here you have to remove, take out the nucleus out of the bag, so you need a larger capsular access. So do a larger capsular access, and then you simply aspirate the cortical matter and little bit of epinucleus that is there. In such big lenses, you have lots of this cortical matter, and the nucleus becomes small, and then you just increase it a little bit, and then you rotate it as Dr. S.P. Singh has also shown you, and Dr. Sharma has also shown, and you can just bisect it, and you can remove through a smaller incision. This nucleus can be easily removed, and make it vertical, the pieces that are there, and can simply remove them and implant the lens. Then you can use limbal relaxing incisions, which are very good to prevent astigmatism and correct astigmatism, and correct that astigmatism that you create. Surgically induced astigmatism many a times causes problem. When we do SICS, it causes 1.5 diopter of flattening. So you can do a limbal relaxing incision on the side. This is the frown incision that is given, and here at this end, just have a look at this point. At this place on the around 90 degree to the incision that we have made, you see just 6 millimeters, and 600 micron incision can be given on the limbus, and this corrects whatever astigmatism you cause. So you get an astigmatic post-operative result. So the vision remains 6/9, 6/6 partial in many of the cases if you use this technique. Nucleus rotation and removal of the nucleus is the same. So this technique can be used by all of us. And if you have post-operative astigmatism residual, then you can correct it by giving more limbal relaxing incisions. That can also be done. This is a technique which is done by Professor KPS Malik, and I have always followed him. And you can see here at this point, if you look at this point, your incision has been made and a vertical cut is given here, and the other vertical cut on this side. So you give this two vertical cuts on the ends of the frown that you have made, and this holds the bridge tight so that the wound does not sag, and the astigmatism caused because of that is prevented. So you continue with the surgery as usual, and this trick can also give you quite a less astigmatism, which is very, very important. Then iris hooks, Professor S.P. Singh has already shown wonderful techniques. I don't need to. Then this is another thing that you can do. Viscoaspiration, as you do in phacoemulsification, they say that we implant the lens under the fluid, and we take the visco from behind the IOL, which is so very important to do. So we simply go through the Simcoe in this and just shift the IOL a little bit and go behind the lens, and you will simply remove you see, just in this way you can remove the visco material, whatever is there, whatever dirt is there, whatever is debris is left there, you can remove this through main port and side ports, and you can get a very good clear media the next day. So this can be tried. Cortical cleaning is Dr. Sharma, I have seen that in all cases she used to make this side port. I many a times out of hurry I not used to make it, but it is a wonderful thing, and your chamber remains quite deep when you are aspirating the cortical matter, and this can be used for the subincisional cortical matter, which is very, very good to do, and you can do the cortical cleaning through the side port and from the subincisional area also very easily. So this technique you can adopt in your day-to-day technique, and you will get better results. Sometimes we may get, as I was discussing about implantation under fluid. So you can see I am using Simcoe, not the AC Ventera in this case. And for implanting the IOL, you see this under the fluid, this IOL is held, haptics are held, and then you simply go inside, and you can see the chamber remains watertight. Almost a little bit of leakage is there, but that you can prevent. The moment the wound closes, the chamber becomes deep, and this way you can implant the lens, and you don't need to too much of cortical cleaning or viscoaspiration post immediately intraoperative. So this can be used by all of us. And this is another chevron incision, as you know, जो आर्मी वाले लगाए रहते हैं इधर, उसको chevron कहते हैं. This can be used by us to what this kind of V-shaped incision is given, and this causes the least astigmatism that can be utilized in your routine surgeries, which will cause less astigmatism, and the patient will get 6/6 vision as he gets in phacoemulsification. So this can be done, and this is an hybrid phaco in which manual breaking of the nucleus is there. So after doing capsular access, making side ports, taking the nucleus out of the bag, just a little bit, just a lift, which Dr. K.K. Mehta calls it as a lens salute. So you just remove it and make it a little vertical, and with the help of two Sinski, you can simply chop it. There is a chopper in one hand, on the other there is a dialer, and just stabilize the nucleus, and you can easily break it into two, and then you can use the phacoemulsification, and you can break it into further smaller pieces if you want to, and you can do posterior capsular access. Sometimes can be done by you. You can see there is a thick plaque in the posterior capsule, and this can be done by simply doing a good capsular access. It's very easy, you can try it, and this also helps. You can see there is a small posterior capsular access, and you can implant the lens without disturbing the vitreous there. So these are some of the things that we can apply in our day-to-day practice, and a good biometry is of course essential for getting good result. Thank you.
Thank you, Dr. Kamal Singh, for such an excellent talk. And small tips and modifications you have made. Then definitely will be very much useful to everybody, and making ultimately a very good success of the cataract and providing a 6/6 vision and controlling the astigmatism. Thank you so much. Now I invite Dr. Lahane for his talk. Especially, visibility is very, very important, but in certain corneal diseases, if that is how you can make the successful cataract surgery without any complication. Thank you.
Thank you, Kamalji Singh sir, SP Singh sir, Ruchi and Ragini. Good morning to all. My topic today is SICS in the corneal diseases. So SICS can be performed in any type of problems. So there is no any financial disclosure. Now you know the corneal opacity with a cataract. So normally there are challenges in the management. You get the challenges. Then there are the visualization of the glow is limited. Guarded visual prognosis is there in the patient. IOL calculation is very difficult because the surface of the cornea is different. Then may need the corneal this intervention sometimes. Then if you see the cataract, if you see, so there are so many I can say challenges in the can see the the keratoplasty also followed by the cataract, or early is all other thing, cataract with the keratoplasty, triple procedure we do. So these are the problems that happens. Now see, this is a patient with the 45 corneal opacity with an untreated subcapsular cataract, and then you can see this is a corneal opacity. So when can see such type of opacity is there, and then behind you will see there is a cataract, and then you can say this is the opacity, then behind there is a cataract. Then what is to be done in such situations? Then we can see the cases where the normally you can see the there is a problems in the, you can see this cornea or results we always get in the problems, and this second thing you can see the, whenever you are doing the can say no, you can say any this anti-inflammatory drugs. So in this case we can't do that. And again you can see this corneal opacity with the superficial and deep, I can say ghost vessels are there, and so there are so many problems when you are operating with the ghost vessels. And so corneal sensation must be checked in every case of the corneal opacity when you are going ahead for this. And the now see the small pterygium less than 3 mm not affecting the topography can be left alone or treated with the cataract simultaneously, because that is not affecting. But a medium pterygium more than 3 mm affecting topography, pterygium to be treated prior to the cataract, because later on the toric or any IOL you are putting inside, so that may be a problem. So large pterygia can say 3 mm affecting visual axis should be treated with pterygium followed by the cataract surgery. Now see this spiral degeneration is there in the lower part, and now I am taking the incision in the superior part. You can see this is the superior cornea, and where I am taking the incision and just you see the making the rexis here, and whenever you are making the rexis, then that opacity comes in between. So whenever you are starting, start in the area where you can see. So in that area where you can see, don't start in that, and then lastly behind the opacity you can complete. So now you can see here, while going in you cut, I always say that, and then I am rotating the nucleus. So that is the superior portion where I can see the cataract, and then this is a glide. Normally I use the Blumenthal technique, and you will see this is coming out from that area, and completed the surgery. You will see this, and then I am aspirating. This is the aspiration cannula. This is devised by us in 96. So we use this cannula, and then the lens is implanted, and your surgery is complete. Only here you will have to also repose the conjunctiva. Can you see, this is the very important step when you are doing the such type of cases. So here the you have seen how you can do the things. Now see here, it is a keratoplasty, and after that now I am doing the cataract. So now here again you will have to go behind where the sutures are not there, otherwise sutures will get ruptured, and then again you will have to take sutures there also. So here you will see the, what I am doing is, whenever I am doing it, I am going behind and trying to see here. Now the sutures I have kept it, and after the sutures, the can you see this, I am doing the rexis. After the see here, the can you see, this is the, can see the rexis I am doing larger, behind the iris I am doing the rexis, and after that now I am separating the nucleus. So here why I am doing this, why not doing phaco? Because phaco may damage the you can endothelium of the your graft, and to avoid that I'm doing the SICS here, you will see. So here we can prevent the endothelium in such type of cases. You will see minimum damage to this. Then I aspirate the cortex, and once I aspirate the cortex, you can see here, and once it is, then the lens is implanted, where I want that the graft should remain clear and it should not be, can say, damaged. So I am doing for that. Then you will see this is the 45 years patient, where you will see the corneal opacity, vascularization, you can't see glow. So in such situation, see, if there is no glow, then how you are going to operate? So now here you will see what we can do is we can use the endo illuminator. So this endo illuminator is there, and you can see now the glow is seen. So this glow, now I have stained the capsule, and by the endo illuminator I am doing the can see the rexis extension is done. Here the phaco is not possible because you can't see anything, because opacity, can you see, it's very, very big opacity, vascular opacity all over. And what I am doing is with the endo illuminator I am completing, and from, if you see from the front, nothing is seen, but only once there is a endo illuminator I can aspirate the cortex properly, also did rexis, and you can see the vessels are seen, opacity is seen, but because of endo illuminator I can see the glow. And with that, now you see, then again I will implant the lens in this. You see, again I will have to use every time the endo illuminator and aspiration few cortex were remaining, remaining, I have removed everything, and after that now I will implant the IOL. This glow will help me. See, this aspiration, I have removed the cortex, and now I am implanting. This is a foldable lens I have implanted inside. You can see the, and then I am dialing in the bag, because there is a bag. So we always think of the, yes, you can implant foldable lens in the this one, and in this case also, the, can you see the centrally there is a small pupil open, patient is having 6 by 36 vision. This is one-eyed patient, so we can't take any other chances. So with the conclusion, you will see the normally preoperative thorough checkup is very, very required in the cases, such type of cases. Then the ocular surface disorders like with cataract needs the holistic management approach in that. And once you do that, cataract surgery should be optimized for every patient depending upon the extent of the corneal disease. So prior counseling about the, you can say, aggregation of the primary diseases, what aggravate ho sakta hai, you can get the corneal, you can say, opacity, or you can say keratitis sometimes, that you will have to tell the patient aggravate will be there. Otherwise patient will later on say, before that I was having the vision and after that my vision is reduced. So to avoid all these things, you will have to tell them properly, and importance of the follow-up here, because you don't know what is going to happen. So you will have to tell them, come on next day, 7th day, 3 weeks, then 6 weeks, like that, and then you can follow. Thank you very much.
Regarding pterygium more than 3 mm, you said treat pterygium and
First, because the astigmatism.
So regarding this vascularized cornea, what I think is corneal opacity is because of vascularization.
Both, it means the first you get the corneal opacity, in that it is vascularized.
But you can cauterize, the opacity also gets.
No, if you cauterize also, that vessels will again come from the other place. So cautery is not the treatment of corneal vascularization.
Thank you so much for excellent talk. I have already shown so in such difficult cases, corneal opacity, how to visualize. So endometer definitely is it will be helpful to visualize even without microscope light. You can operate it. So you have made the things very easy. Thank you very much for this inspiring these videos. And now I request, yes, any comment, Dr. Ruchi?
Just one comment if you would call
Okay,
it.
Arish, yes.
you were talking about the vascularization. I think the genesis of vascularization would be somewhere, there's the limbal stem cell deficiency. So, so I think sir was talking in general, but yeah, that needs to be addressed, and that is not the end of the story. So if it is there, you must take care of your corneal release, maybe slits and all those would be the point. So basically what sir was trying to show was that with the endo illuminator you can do the cataract. You have to deal with the corneal opacity and the vascularization, but what he wanted to do was to show it as a two-step procedure, because doing a one-step procedure treating the corneal disease and the cataract as one time is not something he wanted to do. In this case what he wanted to show was the use of the endo illuminator to do a cataract surgery, which is made easier in the presence of a corneal opacity with vascularization. So you can, sir, I think we are about 15 ophthalmologists and everybody has their own way of tackling it, because we have our own practices and medical colleges. So this is our way of doing it. Definitely there are other ways of doing it.
Whenever we all are experienced people. So everybody has got his way of doing. So if your way is different, then that is, I think we agree that what we do, that I am telling. So that is, IC is for that only, what we are doing, that I am telling. So you can have the different way of tackling, there is no problem. Okay, thank you. Yes.
So if it is a pure neovascularization, you have to proceed as fast as said. And if you are talking about limbal stem cell deficiency, then it is entirely
Different. Opacity and vascular, this limbal, what madam says is very true. So limbal cell deficiency, you will have to treat totally differently. And vascularization, if you do diathermy, that may help, but temporary benefit.
Before they come back.
Yes, they come again.
Yes, now I request Dr. Ragini, is from Mumbai. He's also having a lot of experience in doing SICS, and not only SICS, FECO as well, but he also popularized this SICS in difficult situations. Certain situations sometimes it's difficult to perform the FECO. So the SICS is another option, good option. If you make the vision 6/6 and control this astigmatism, this very equally good. And the subluxated cataract is again a very challenging situation. And now how can proceed? So I request that.
Thank you, sir. Respected Singh sir, my teacher Padma Shri Dr. Lane sir, my close friend and promoter and teacher of SICS Ruchi, Dr. Shama, all respected seniors and friends. So SICS and subluxated cataract. There are situations which are different than in which cases you don't want to or you are scared to do phacoemulsification, and that is when SICS comes to the rescue. The risk factors will be trauma, previous ocular surgery, multiple intravitreal injections, Marfan syndrome, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, sulfite oxidase deficiency. These are some conditions where you find that the cataract could be subluxated. And if you have such a patient, then it is better to look for it, do a slit lamp examination, and be aware that subluxations can be possible. Progressive and generalized weakness can be in trauma, previous ocular surgery, multiple intravitreal injections, Marfan syndrome, homocystinuria, pseudoexfoliation, Weil-Marchesani syndrome, and sulfite oxidase deficiency. These are conditions where one must be aware of the pre-existing subluxation. So how will you manage the patient? Investigation, preoperative precautions, intraoperative care, and the postoperative monitoring. So we divide the management into these 4 parts. Now, we are talking about investigations. So a slit lamp examination, if possible a UBM, if you have access to it, it is expensive, so you have to consider the patient's finances also.
In cases of trauma, there may be associated injuries or something abnormal in the posterior segment. So B-scan ultrasonography, even for medico-legal purposes, and retinal examination, these are very, very important. So pre-operative precautions we will be going to. So you have to counsel the patient, which is very, very important, that the need, the presence of a complicated and the need of a prolonged surgery, the potential need for a vitrectomy, the risk of retinal detachment, cystoid macular edema, and vitreous loss, the need for a second surgery because primary intraocular lens may not be possible. Management will include investigations, pre-operative precautions, intraoperative management, and post-operative monitoring. So whenever you are trying to do it, it should be, the incision should be placed away from the area of zonular weakness if possible. It may not be always possible. Incision in the gradient opposite to the zone of maximum zonular weakness, but at the same time we should not jeopardize his surgical ability by operating in a meridian that we are uncomfortable. Sclerocorneal incision allows the ease of incision to be converted into a SICS. A generous amount of highly retentive viscoelastic is important because you want to maintain and you want to prevent the vitreous from entering into the anterior chamber. Capsulorhexis, it is important that in the capsulorhexis, you need to do a proper capsulorhexis. Here the capsule is not firm and you may need to use a Utratas forceps. The use of trypan blue is very, very important because it helps you with a better visualization of a capsule so that the rhexis is performed properly, and it should be centered on the crystalline lens and not center of the dilated pupil, because the lens is first decentered. So if you center it on the lens and use CTR rings to then bring the capsular bag in place, then it should be centered on the lens. So that is very, very important. So as you can see, this is a subluxated cataract SICS where we are doing a dye assisted rhexis. This is a capsulotome which we are using, and it is centered on the decentered lens. So as you can see, the capsulorhexis appears to be decentered, but it is centered on the decentered lens because now after the rhexis we are going to use a CTR ring to bring the lens central. So this point is very, very important. Hydrodissection, you have to be very, very careful by doing these procedures because the amount of fluid can cause more subluxation. So one has to be very, very careful in doing these procedures, and it has to be customized to each case. Now, after hydrodissection and hydro procedure, now once you have finished the surgery, there are two schools of thought that orienting the IOL in a plane parallel to the zonular dialysis. So you have to see where the bag will be stretched and where the IOL is placed in order to inflate the bag and make the lens central. That is very, very important. So orienting the IOL in a plane parallel to the zonular dialysis in order to take advantage of the remaining intact zonules. It will provide optimum support but may cause ovaling of the capsular bag. So that you have to be very, very important. And placing one haptic in the area of zonular dialysis will ensure stretching and decrease ovaling. So that is also very, very important. CTR rings have changed the way we look at subluxated cataracts, and they have made our life much, much easier. They are a prerequisite to the management of subluxated cataracts today. So they have demonstrated that they stabilize the bag. There are various sizes available. Depending on the white to white, you have to use a particular size ring, because in bigger eyes or myopic eyes, a big ring will be required. So these are the various types of rings and the sizes which are available. Like we order intraocular lenses, various sizes are available. So they can be inserted using a forceps or a specially designed injector or a fishtail technique. And CTR is fixed to the sclera using either an ab externo or an ab interno approach with a suture, right? So what is the fishtail technique? It can be used to insert the CTR where both ends are held with the forceps in a cross manner to create a central closed loop which is placed adjacent to the area of dehiscence in the capsular bag first. So that is important, and then it is released. So this is the CTR ring. As you can see, you are holding the ring with both hands and then gently putting it in such a way that it is being rotated gently into the bag. One must remember that it is a C-shaped or a circular ring. Now this eyelet, you hook the Sinski's hook in the eyelet, and now you put it in like you put in a loop. So that is very, very important. So putting in the ring is also a important technique to learn. We have found patients with multiple CTR rings in the vitreous. So when do you insert the ring? Either you can do it before the nucleus delivery, where you think that you need to stabilize the bag before the nucleus delivery, or it can be done after the nucleus delivery before the cortex aspiration. Each case warrants different type of insertions. So that is very, very important. It should be stabilized. So putting it before stabilizes the bag and does not cause more subluxation during nucleus delivery. So I think putting it before helps me more, and it should be inserted with a simple forceps method. So contraindications of a CTR are where you do not have a rhexis, when there is a PC tear, when there is an extensive zonular weakness, and it is not used in patients with scleral disorders because it can be excluded through the sclera. So these are very important, and like I said, we found patients with multiple CTR rings in the vitreous when they came for IOL explantation. So lots of things have been tried, and then, so as you can see, this is a patient where we are doing this is a subluxated cataract where the rhexis is done, and you can see the traumatic rosette in this patient which caused the subluxation. So the rhexis is in the center of the lens. This case is used to just demonstrate certain points and the small multiple points of hydro, as you can see. Because this is not an SICS, this case is shown to demonstrate certain steps where the nucleus is separated gently and brought out of the bag, so there is no tension on the bag, because if you do anything inside the bag, so you can see even after slightly that the nucleus is removed, small hydro is done to bring the nucleus out of the bag. So that is very, very important, because if you put too much of fluid inside the bag, it will cause more subluxation, and it will cause more harm than what you want. So one has to be very, very careful. So investigations, preoperative precautions, intraoperative and postoperative monitoring. So postoperative also is extremely, extremely important, because these are the cases that cannot be left like that only. You have to check for centration of the IOL, any remnants of vitreous, because those have to be removed by vitrectomy by using tricot, and you have to see for the check of the pupil, you have to see the shape of the pupil, because the shape of the pupil will tell you whether there is any vitreous in the anterior chamber. Post-operative rise of IOP because of so much of manipulation, inflammation, and the presence of vitreous in the trabecular meshwork. Pseudophacodonesis can also cause cystoid macular edema like phacodonesis, so one must be aware and treat it beforehand, and a retina examination, because any pre-existing holes or tears can cause retinal detachment. So basically, the take-home message is that subluxated cataracts can be given satisfactory post-op results with proper preoperative planning. Use of CTRs when indicated, I think it is a big boon. Optimum bottle height, because you do not want too much of fluid to cause even more of the capsule to be subluxated, and it is important to learn a proper vitrectomy to manage a small anterior vitrectomy is a must to manage these cases and to prevent any problems. So, yes, sir.
Thank you, Ragini. I think in the very good steps of the can say subluxated cataract, and I think we have completed the talks of the this IC. So I am thankful to the Singh sir, also the Kamaljit Singh sir, then the Ruchi and Dr. Ragini, and also thankful to the Dr. Kshama and Pranav who presented here. And thank you all for coming Sunday in the morning at 8 a.m. because the 8 a.m. is very difficult to come after the Saturday. So thank you very much.